Good morning, everybody. It looks like we have attendees joining us, so we'll pause for about 15 seconds or so to have additional folks join, and then we will get started with a couple of logistics reminders before diving into the content. All right. Well, we're at about 130 attendees, which is great. I just welcome everybody to today's webinar. I'm going to start off by a couple of reminders. We do have live captioning and ASL interpretation available. To enable closed captioning, you can select the CC or live transcript icon on your toolbar. Recording slides and transcripts will be posted within the next 5 business days to the California Health and Human Services Master Plan for Aging webpage. And it's the same page where you can find an archive of past Webinar Wednesday materials, recordings, and transcripts. We are looking forward to your questions and comments and are saving time towards the end of the webinar for that. If you're joining us by Zoom, you can use the Q&A function or the chat function, which is open today, to let us know what your questions and comments are. And we encourage you to do that throughout the webinar. You can also raise your hand, and that will add you to the queue for us to unmute your line and hear from you directly. For those joining by phone, you can press *9 to raise your hand and we will unmute your line. And as always, for additional information or feedback, or if you think of things after the webinar, you can always email engage@aging.ca.gov. And with that, I am honored to introduce Director Susan DeMorris of the California Department of Aging.
Thank you, Maria, for starting us out, and thank you so much to our team at the Department of Aging, Sarah Steenhausen and Amanda Lawrence, who planned and organized today's webinar for all of us, and a special thanks to each of the panelists that you'll be hearing from. I'm very much looking forward to hearing your remarks and to hearing the conversation among our what is now 171 participants on today's webinar. I just wanted to reflect for a minute that today's webinar is a continuation of a conversation or conversations that started well before the Master Plan for Aging, continued throughout the Master Plan for Aging process. We have recommendations in the Master Plan for Aging focused on nursing home issues. And we know that in the midst of the COVID pandemic, which still continues, there have been very intense and focused conversations on nursing home issues in our state. So today continues conversations over many years' time, and we won't conclude today talking about the issues, challenges, and opportunities in California's 1,200 nursing homes. Today is a launch for more conversations with more audiences and more voices to continue this conversation as we return to the values that I know everyone on this share in our state, the values of quality, equity, access, financing, workforce. We'll touch on these topics today, and we're very fortunate that we're having this webinar today because we are at a critical juncture in California's timeline. We have the Biden administration just last month released a series of recommendations. We have legislation active with the state legislature. There is a proposal in the governor's budget around nursing home rate reform and financing. So this comes at a really critical time, and we just thank you all for participating, joining, and we invite you to comment today, but to keep the conversation going well after today. I now would like to introduce our partner in the year-long Wednesday webinar series. We are partnering with the California Commission on Aging for each of these monthly webinars, and today we're delighted to be joined by Erica Castile, who is a member of the California Commission on Aging and also Executive Director of Jacob Healthcare Center. And I'm pleased now to turn it over to Erica to make her remarks. Welcome, Erica.
Good morning, and thank you for having me. Welcome everyone on behalf of the California Commission on Aging. I am a commissioner. I've served for about 1.5 years. The commission is an independent state body statutory mandated to serve as a principal advocate for older Californians and seeks to be a catalyst for change that supports and celebrates Californians as they age. That is our mission. We recognize that in the past 2.5 years, it has been a challenge for everyone. And as mentioned, even prior to that, as we have seen some statutory changes in regulations in 2018 under Title 22, when we had our staffing increase and mandates regulated, in particular to the direct care workforce and CNAs in particular at that time. On the front line, providing services has been affected in our nursing facilities, assisted living facilities, and our general care workers across lines. As someone who operates a community, I am not just an operator, I am also a gerontologist. I also serve as the California chapter president for Healthcare Facilities CAP. And I've worked directly on the front line, and I've seen our superheroes just do an amazing job and all the support they've gained over the time. And I'm excited to work with the commission and partner along cross lines to help come up with solutions on how to better serve our Californians in the future. As the workforce shortage became more acute, the commission identified the workforce development, specifically strengthening the direct care, gerontology and geriatrics, and related workforce as a priority issue area for 2022. Thank you for the California Department of Aging for inviting the commission to participate in the Wednesday webinars. They've been very helpful, and we've been very grateful to have been a participant. We welcome everyone today to today's webinar on behalf of the California Commission on Aging, and I'm looking forward to today's discussion. Thank you so much for having me.
Great, and we'll transition to Holly.
Hi, thanks for having me too. My name is Holly Lewis, and I am speaking on behalf of what it's like to be caregiving for my mother and supporting her in her skilled nursing facility here in San Luis Obispo. She's been there for about 3.5 years. And my mother's name is Catherine Phillips. She is a mother of 4 and a grandmother and a wife to my father for over 45 years. I would say about 8 years ago, my mother started to get really tired and kind of depressed and declined and stopped driving. And she has type 2 diabetes and had some other health issues. And we started noticing her decline. I wanted to give you a little bit of a backstory about my mom. We tried to get her out. We tried to do lots of things. She had just kind of a loss of interest, and then slowly started to decline and have falls, and would go to rehab in the hospital and come back home. And our last effort to keep her home was very hard to manage. It was my father and I who basically were caring for her needs, and it was too much for my father as he was getting older as well. And so she ended up going into the hospital and having to go to rehab again for like a 3rd time. And she never made it home after that. She had a pacemaker put in shortly after in the middle of her rehab. And when my father and I go back and look, what went wrong here in the system? At that time, I can tell you our experience was that my mother had this pacemaker put in, and she was walking at that time. She was walking with a walker and support, and she was getting better. And when they decided that she needed the pacemaker, it basically pushed her back in her rehab. In fact, they stopped walking with her. They said that she couldn't pull up on the transfer pole. And several years later, after my father and I would look back and say, well, what could we have done? Why wasn't anything done to modify how she got up? Obviously, she couldn't pull up on this pull-up bar because it would tear the muscles for her pacemaker. So we thought, well, why didn't Why didn't they think of other ways to get her up so she can continue walking? And what ended up happening is my mother became bedridden after that. And she had a pressure ulcer that kept her bedbound for several months leading up to COVID. And right before COVID, it healed and it was going to get better. But even before COVID at her facility, when she went in, she wasn't supposed to be there for long term. It was supposed to be rehab kind of slowly, but they had to move her to the long-term area because she had exceeded her time in the rehab area. What ended up happening at that time was there was a lot of staffing issues right the year before COVID at my mom's facility. And we didn't know enough about the system to navigate and to understand what was going on. But because there was a lot of staffing issues and other things happening, call lights were being answered for 45 minutes. My mother couldn't get up on her own to use the facility. And so what happened is her behavior spiked. And I work with special needs, so I know a lot about behaviors and environment. What happened at that time, and I wasn't really aware, I was new to this whole system, that my mom's behavior started to go up. And next thing you know, medications started to be suggested to use for those behaviors. But we didn't realize that maybe some of them were just natural progression of some dementia that she was starting to have. But a good amount of it was from her environment that caused her behaviors to spike. And eventually what happened is she got hospital dumped by her facility. They said they could no longer care for her. And she went to the hospital, and there at the hospital, she wasn't getting up and wasn't getting in the Hoyer lift and getting out, and was in the bed at the hospital for about a month. And I advocated as much as I could to get her up in the wheelchair, at least out of the room, and just advocating for those basic needs, those basic care. I was really surprised that I had to do that, to be honest, in this setting in the hospitals where these things should just be automatic. They weren't. I had to advocate. I had to call. I had to request over and over again. The hospital did ended up helping us get my mom back into her facility. And shortly after that, her facility at that time, no longer, another company took over her facility. And then shortly after that, COVID came. And when COVID came, my mom, she has some dementia, but she's also with it. And I can tell you that everything that I had to learn in between that time where she was hospital dumped, I had learned what an ombudsman was. And our local ombudsman, Karen Jones here, it was my right-hand man and still is, but I've learned a lot from her, and also from CANAR. I reached out to those organizations because information for me as a daughter who was coming into this nursing care, long-term care facility program, I had no idea how to navigate. So shortly during that hospital dumping situation, I quickly learned who to go to. And then COVID came and we were locked out. I got my mom a phone and we window visited with her. Thank God we visited with her twice a week, because the natural decline that was written off for so many people wasn't always a natural decline. In fact, at one point, my mom wasn't able to reach for her cup, and I knew something was wrong. And we saw something happening for about 2-3 weeks. And I said, something's wrong. And it turned out that she had an internal bleed. But what happened with COVID is so many people who had real symptoms that weren't related to COVID were kind of in a veil of this COVID veil, and they didn't put 2 and 2 together. And because we were so actively involved in my mom's care, my father and I, we knew something was wrong. And at that time she went to the hospital, and I'm going to try to keep this short, so hard. That was the only time that we got to actually be with my mother in person, was in the hospital. And so during COVID, it was very, her facility did everything they could to facilitate FaceTime calls, but even that was very difficult. I'm glad that my mom had her own phone so we could keep in contact with her. I'm going to look at some of my notes because I know I'm pressed for time here, but I do want to say here that support day to day is for basic care, medications, and what did I want to say here? I find myself having to go over and over my requests for my mother regularly. Things that were on a care meeting 2 years ago, we're still having to come back to because they're not being taken care of. However, the staffing issues are, you have people that are working in the nursing homes that have been there. The same people that were there 3.5 years ago are some of the same people I see today, and we see a lot of new people. Because I have so much to say, it's so hard for me to isolate what needs help, because there needs to be help everywhere. But one of the things I can tell you is that we're not paying our CNAs enough. I'm often at my mom's facility and the halls are empty. They're doing a great job, but a lot of the people who are committed are there, and we see new faces. But I do feel like our CNAs need to be paid more. We're not paying them enough to care for our loved ones. And my mom's basic needs, like grooming, taking care of her nails, making sure that she's not isolated. My mom's bedridden. And I have to say that a lot of the people that are up and doing activities in nursing homes are people that are either able to push themselves around in the wheelchair or walk. And the ones who are in the beds don't get up. Nobody comes in and takes them out of their room and brings them into the activity center. It's really up to the families to do that. And that needs to change, because so many people who are in their beds who cannot, my mom has her own room, so many people who are in the beds and can't get out to see other people. They're isolated, they're not getting socialized, they're severely depressed and declining. And the staffing is still an issue. I think it was before COVID, and it is, and we need to make sure people are getting paid to be there, and maybe more people would take these jobs caring for our loved ones in facilities if the pay was better. And that's really what I want to say here, because I do believe that's really what it comes down to in some ways. But I wrote so many notes, and I just feel like I'm just wanting to speak from my heart to tell you guys that when people are transferred out of facilities and going into hospitals, I can tell you that my mom's medications lists weren't updated oftentimes when she was transferred, and she was given wrong medications several times. That thankfully I was there and I advocated to be there. Otherwise, my mom would not have been able to know what her medications were at that time. That was another thing. Rehabbing, making sure that when people go into a long-term care facility where there's a rehab, that there's enough staff to support people getting out and getting back to their life. Even if they have a few years left at home with their loved ones, that they have those years, that there's support for them to get the rehab that they deserve. I don't feel like my mom got that. Also, I wanted to say the importance of visitation. And I'm a part of the Essential Caregivers Coalition, and we also have been advocating, and there's a bill, hopefully it's being passed soon, for the Essential Caregivers Act, so that this will never happen again where loved ones are locked out of a facility. Because if it wasn't for me and my father being so involved in my mom's care, she wouldn't be here today. And human rights is hugely important. My mom's basic care needs, people just not being isolated, and communication in the departments between nurses and CNAs and families and doctors, and it being consistent is huge. It's huge, because I can make a request to her facility and I could say it to a nurse, and then all of a sudden, or at a care meeting, and it's not going across the board. Where, for instance, I'll just say this, where my mom is bedridden, she hasn't been able to reach her water for several years. And I've made just a basic request. Can we angle this tray in so she can reach her water? And I'm continually having to make the same request over and over again, just for her to be able to reach her water. And that shouldn't be happening. And I don't know what else to say. I just want to say how important it is to support the people that care for our loved ones, and showing up and being present for your loved one and being involved in their care is huge.
Thank you so much, Holly. Thank you for sharing your personal experience and for your advocacy. We're so grateful to have you here to help us connect policy with what really happens on the ground. And I'm seeing lots of support in the chat too. So I think many of the folks who are joining us today are seeing that connection and may have experienced similar things in their lives. And with that, we're going to turn it over to Nicole Howell.
Thank you.
And give us a moment. We got to switch our slides a little bit and get set up for Nicole's presentation.
Hello, everyone. I want to thank you for being here today and appreciate Holly leading us off with such a really hard story, but I think that should be the foundation of our conversation today. So I like to start off with a beautiful quote from Maya Angelou. Most people don't grow up, most people age. They find parking spaces, honor their credit cards, get married, have children, and they call that maturity. But what is that? It's aging. And then a quote from my own mother, which is, aging is hard. And I think that really helps to illustrate the perspective we should have as we move into these conversations, that we are navigating territory that is unknown to us and doesn't feel comfortable. And so let's keep that in mind. So as we move to this next slide, my job here today is to kind of do some level setting for you. So what we are talking about today is skilled nursing facilities. However, we can't look at things in a vacuum, and so it's important that we understand the scope of what we're talking about. So you'll often hear the phrase long-term support services, long-term care, and it can mean lots of things. So for this conversation, we're talking about long-term care, the congregate variety. And what that means is folks who are choosing to live in a congregate setting and they're receiving care to support them there. They are typically older adults, although we do also see some adults with disabilities. But what these facilities do is their job is to help people to be supportive and to be successful. But let's define what they are, because I think a lot during COVID, terms got confusing. If you were to watch the news, you would simply hear the term, convalescent hospital, but you would know that based on the name, they're talking about your assisted living down the street. So in California, we have a term called residential care facilities for the elderly. And what that means is that is a social model of care. You probably have that assisted living in your community, and it's kind of like a cruise ship, right? On a best day, you've got activities, you have food, you take a walk around the Lido deck. That's kind of an assisted living, right? But in California, we also have what sometimes gets termed a 6-bed. And that is the same level of care delivered in a home-like setting. In fact, you probably have these facilities in your neighborhood and don't even realize it. Both assisted living and 6-bed are the same level of care. They're overseen by California Department of Social Services, and there are restrictions on what can be done for someone inside that building. So that is not a medical model of care. Now, skilled nursing facilities, which you hear a lot about in the news, skilled nursing facilities are indeed a medical model. They look similar to what you might encounter in an acute care hospital: long hallway, rooms with lots of people in them. There's a rehab happening, there are activities and food, but it is indeed different than the residential care for the elderly in that they have a nurse on duty, generally speaking. There is a medical director and a director of nursing. And so there are certain requirements that they have to meet. So this is where I think it gets really interesting to talk about, which is that they are paid for differently. And sometimes payment is what is driving quality, or at the very least, it's part of the conversation. So as we think of this process, think of skilled nursing facilities are generally going to be paid for in a couple of ways. Medicare is going to pay for those short-term stays. Oops, I broke a hip, I had a replacement, and I need a little bit of rehab. But those kinds of stays are diminishing. As our surgery advances, folks are able to go to outpatient surgery centers and return home on the same day. So we have a lot of folks who are in skilled nursing who what you might call custodial care. And so that means that that's really their home. That's where they live to receive care and supports and services. And that is generally paid for in California with what we call Medi-Cal. And that's because we like to be special in California. The rest of the country calls that Medicaid. Some people may choose to pay privately, that is possible. But oftentimes, if you have a choice and you have resources to pay, you're going to choose to go to that residential care facility for the elderly because it is indeed less institutionalized. And so this is just an important framework when you're sort of angry because you hear that your daughter's best friend's aunt is being mistreated in a skilled nursing facility, and you're like, what does that mean? What's the name of that? Who oversees that? It's important to think of, okay, who oversees? So skilled nursing facilities, their enforcement body in California is California Department of Public Health. Residential care facilities for the elderly, California Department of Social Services. So Nancy, if we could go to the next slide, please. There is a bit of a mixed match of who regulates who, right? And so it can be very challenging. So if we're talking about skilled nursing facilities, Center for Medicare and Medicaid Services is what sets the policy based on legislation for what is permitted for payment and certain standards. And so in California, Center for Medicare and Medicaid Services, or CMS, we like to drop an M, they actually sort of contract with California Department of Public Health to implement those regulations, be to certify a facility, to evaluate a facility, to issue citations, potentially close a facility. But sometimes what you will hear is, if you're talking to a surveyor, if it's taking a minute, we're looking to see if we're going to do a federal enforcement or use some state guidance. The federal guidance is always going to supersede. It's going to be the stronger guidance. And that is sort of the underpinning of what we're going to talk about later on with the White House initiative. So it can feel like a really significant mess, but there is a lot of areas in which we can move and improve care, even though we as a state, we're maybe not quite as mighty as the federal government. Some states, like California, have chosen to ask for more than what facilities are required to provide in other states. So for example, we have some additional cost reporting that we'd like to see, and we would have some additional transparency. And so it's important to note that as consumers and advocates, and we're talking about master plan and what that looks like, reimagining the future, is we can choose here in the state of California to lead the way and implement recommendations without waiting for the federal government. There is lots of opportunities there. So we're going to go on to my next slide. And so let's talk about what informs long-term care. I'm sure you have heard that lots of times people are thinking, gosh, we should call someone about that. Who do we call? So again, remember the Center for Medicare and Medicaid Services sets the regulation. And there's a couple advisory bodies that advise Congress. So you have MedPAC, and they advise Congress on Medicare policies, rates, and what's going on. They issue 2 reports a year. March just came out a few weeks ago, and June. And those you can access free, and you can look online and really get a sense of what the advisory council is suggesting and how payments are changed. You also have MACPAC, which is, MACPAC is again going to govern Medicaid. They're going to make advice to Congress on Medicaid and Medi-Cal. Now, the big underpinning is Section 1819 of the Social Security Act. And that oversees payments to skilled nursing facilities. And then there's a second piece to that. Section 42 of the Federal Register is what outlines conditions of payment. So let's say a facility falls out of compliance. They'll essentially receive a letter from California Department of Public Health on behalf of CMS saying you no longer meet the conditions of payment for Medicare and Medi-Cal. And so you'll need to write X amount of things before you become eligible for payment again. And so those 2 are kind of the federal underpinnings we're looking for. Now, there are some other bodies that do get involved in specific instances. For example, the Department of Justice, they may seek enforcement around an elder abuse claim. We also are governed currently by the Nursing Home Reform Act of 1987. And for those of you counting, that was a few decades ago. So as we have this opportunity to have this new White House initiative for skilled nursing reform, that's how long it's been since we've really come back to this topic and looked at it holistically. There's also some provisions in the Affordable Care Act that govern skilled nursing facilities. Of course, in California, we'll also have the Older Americans and Older Californians Act, which authorizes your long-term care ombudsman, which are the people who you heard Holly talk about, who work with residents and families to ensure improved care and ensure residents are, respected, dignity, and of course being cared for. Now, in California, there's also the Medi-Cal long-term care carve-in that next year will come under Medi-Cal managed care. And so that's another opportunity, another lever we're going to be able to pull to support residents in long-term care. And on the next slide, we see how you can be involved in that. So there is a CMS Quality Conference. It's virtual. It's free next week. I encourage you to go and sign up for that and participate so you can see what CMS is talking about. Now, CMS governs a lot of things, so it's not only going to be focused on long-term care, but in light of COVID and the White House initiative, I'm pretty sure we're going to hear some things about that. Also remember that when there is a proposed legislation or rule, the committees that govern these areas of jurisdiction, like Ways and Means or Energy and Commerce, they put out hearings and they invite feedback. You can track those and you can send in comments about what they're talking about. You also, when CMS is proposing a rule, you can give stakeholder feedback and CMS is required to reply. You can always submit those comments. That is a great way to ensure that the advocates' voices are heard. As someone who's read through some of those letters that come to the committee, I encourage you to make them succinct and clear and focused on the topic. But you can be part of this process. And on the next slide, this is really from the Kaiser Family Foundation. This talks about the billing across the long-term support services. And the piece that I want to draw your attention to is that 6 in 10 residents in nursing homes are paid for via Medi-Cal. So when we're talking about what long-term care looks like in California, it's important to note that at Medi-Cal, that's state dollars, and we could have some flexibility around where we want those people to live and what our expectations are. I also think it's always important to note that if a long-term care facility is certified through CMS, you'll sometimes hear, we heard Holly say, mom had to leave a short-term bed to go to a long-term bed. Well, the truth is, if their beds are there and they have an open bed and they are CMS certified, any bed is a Medi-Cal bed. And so I think that's really, as we're talking about later on, 1629 of ensuring care and access, it's important that we ensure access for those that need this the most and do not have resources to pay for it. Thank you, Dr. Wasserman. He put the link for the CMS Quality Conference in the chat. Now, in California, we have something called 1629, and it started in 2004, and it was initiated as a way to improve care, particularly for Medi-Cal residents, and ensure that they have access, and move away from a payer-based model to a value-based model of care. So it's been around for a long time, and our legislator, in their wisdom, have renewed it continually. And you may have heard about it last year when we were talking about that in relation to some other budget concerns. And so it is up for reauthorization again this year. And we don't yet have the full recommendation, but I think there's some important things that we could focus on, which is that essentially this is really about moving a methodology that reflects staffing levels associated with quality of care for residents. There's direct staffing cost, and then there's indirect staffing cost. So the folks who are working directly with residents, and then those residents that are really making sure that life in the facility runs, like housekeeping and the kitchen and the front desk and the MDS coordinator. So there's various costs that you can bill for, but they're all going to be scrutinized to look at what the reimbursement rate is based on the value of the residents are receiving. There's going to be some facility-specific cost-based per diem payments. And that is what would set the agenda. Now, again, remember, this framework is going to sunset this year, December 31st. So the department is proposing to extend that, but reform the framework. And so this is going to be an area of rich conversation. as we talk about this, I want to remind folks that we just came out of a pandemic, or are still coming out of a pandemic, and we saw those detrimental effects on residents in long-term care and how terrible that was for them, either because they suffered the effects of COVID or because they were isolated for nearly 2 years because of it. And so as we're talking about what we want our skilled nursing facilities to look like, let's really do our best with the frame of what we've come out of. So on the next slide, we are going to talk about the White House initiative. So I've left the link down at the bottom, and I'll drop it in the chat when I'm done talking. The White House initiative, President Biden and the Biden-Harris administration made a big, bold proclamation the day before the State of the Union. And the president even mentioned reforming skilled nursing facilities in the State of the Union. And the first focus is we want to ensure that taxpayer dollars are supporting nursing homes that provide safe, adequate, and dignified care. So basically, we want to make sure that, remember, it's tax dollars that are paying for long-term care for skilled nursing facilities, and it's our job to make sure that they're providing the best possible care. So is that via staffing? Is that moving away from 3- and 4-person rooms to more like single or double occupancies? Of course, ensuring that our regulatory agencies like CMS and California Department of Public Health they're giving appropriate oversight. Are they looking at chains and seeing if they have problematic behavior? Are we reviewing what facilities are owned by private equity firms to ensure that the funds that we are paying is going to resident care and not to shareholders? We also want to increase transparency. Our data systems are really challenged, and we have a lot of disparate information, but not all of it cross-cuts. I'm sorry, Sarah, did you want to cut in?
Nope, I'm good. Thank you.
Sorry, I thought I heard it. We also want to create pathways for good paying jobs. How many times have you heard in the news in the last few weeks, months, and years about there's a critical shortage of caregivers? Well, it's true. And part of that is because we need to provide a pathway that helps workers gain skills, confidence, and keeps them in the long-term care industry, but also has mobility. And first and foremost, to Holly, I agree, they need to be paid fairly. And I just want to say, for me, that isn't just a 2 or 3% increase. This has to be a wholesale increase of substantive happening so that folks actually want to stay in the sector. We also want to make sure that ensuring pandemic and emergency preparedness in nursing homes. We have all heard terrible stories about what happens during fires, during earthquakes, hurricanes, tornadoes. Skilled nursing facilities of today are really old buildings, often built more than 40 years ago, and we must require that these facilities are prepared to either shelter in place, evacuate, and still respond to care needs. So I believe that is my last slide. I want to thank all of you. I'm excited about this conversation, and I'm really eager to see what the future of nursing homes look like in California.
Thank you so much, Nicole. You just have a knack for taking a very complicated subject and breaking it down for us, and so very much appreciate your time. And with that, I would like to introduce Sarah Steenhausen, who is the Deputy Director of Aging Policy Research and Equity at the California Department of Aging. And Sarah's going to introduce our amazing panel today.
Great. Well, thank you so much, Maria. And I can't thank our prior speakers enough. First, to Holly for sharing her very powerful story, which I think really will inform our policy discussion, because I think, as we all know, the purpose of our policy reform is to respond to both what residents needs and what the caregivers need, and how we can ensure the highest quality of care for all in our nursing homes. But second, I want to thank you, Nicole, for an incredible overview. You know, your background as executive director of one of the long-term care ombudsman program in Contra Costa County of Empowered Aging, and your role as a health and aging policy fellow at the congressional level really gives you a breadth of understanding of the system. So that was extremely helpful to kind of ground us in where the policy levers are for change. So with that, I want to introduce our wonderful panel, and we can bring them up online when you're able to, Maria. First, we are joined by Blanca Castro, California State Long-Term Care Ombudsman, Eric Carlson, who is Directing Attorney with Justice and Aging, Heather Craig, who is Executive Director of the Eschaton Care Center in Greenhaven. And then finally, as you know, Nicole Howell, who just spoke and will continue to provide her perspective in our panel discussion. So I think we can take the slide down. And I wanted to say before we get started, we would love first to hear from all of you in the chat, for you all to introduce who you are, where you're from, what your organization is, and anything else you want to share. It's always nice to know who's joining us today. Second, we want to hear from you in this conversation. We want to make this as engaged as possible. So, any questions you have, I love watching the comments that have been coming up in the chat. We want to weave those into the Q&A, but also we would like to hear from you. So if you actually want to speak after all of our panelists have made their responses to their opening question, just raise your hand and we will call on you as we can. You could also just choose to put your comment in the chat and we will track that. So with that, what we're going to do here is we're going to start off with an opening question that is crafted especially for each of our panelists so that they can provide their perspective. We've really tried to make this a balanced perspective, including advocates, resident perspective, the long-term care ombudsman, and the provider perspective. So we really want to hear all ranges of policy considerations in this discussion. So with that, I'm going to start with you, Blanca. And Blanca, my question for you is, you are California's long-term care ombudsman. And in this role, you have a responsibility for overseeing the state's network of 35 long-term care ombudsman offices that, as we've heard from both Nicole and Holly, they play a critical role in assisting residents of both assisted living facilities and nursing homes with issues related to their day-to-day care and their personal needs. Can you speak to how the ombudsman role was impacted by COVID and what lessons were learned and what your goals are for the program now and into the future?
Good morning, and thank you very much for this. What an incredible panel we have, and really appreciated Holly's first-hand experience. So just to remind everybody, ombudsman is actually a Swedish term, and it just means a person or an official who investigates complaints lodged by private citizens against businesses or public entities or officials. So it's important first to explain to everyone what the role of our role is to provide a real overview of what lessons we learned. And the strength of the state long-term care ombudsman is its access to residents. The program and the over 600 staff and volunteers across the state, in order for them to perform their functions, they meet people in person. They're often at their bedside. And so a lot of times they do need privacy to be able to meet with residents. They do their work as a resident-centered approach. They monitor, confirm complaints or situations that are lodged by residents. And overall, the role of the ombudsman is to resolve complaints in protecting people's health, safety, and welfare rights. So what we learned from the pandemic is that first and foremost, our access was denied at the beginning. We weren't able to do the work initially that we have been able to do without a COVID pandemic. And that really affected nursing home residents and their families. For example, just to give you an example of what this resulted in is normally in 2020, we had about 29,265 complaints that ombudsman received. In 2021, we had 37% increase, 40,178 complaints received. The top priority or categories of those complaints were in the area of abuse, neglect, and exploitation, medication, autonomy, choice, and rights. So it was very much still a need to have volunteers and staff entering facilities, but because we were unable to, we had to come up with other ways to do the work. So if there was anything that required immediate attention, certainly we would refer that to law enforcement, to others. But for example, the advanced healthcare directives, the state law requires that in an advanced healthcare directive, and that is if something were to happen, you're not able to give your wishes on your health care. You want to be able to write down what those preferences and those wishes are. And so normally we have to witness those documents and sign them. Unfortunately, we weren't able to go in, and so we found ways like video conferencing, in some cases taking pictures or going through a window. And that's how we did some of our investigations, actually. So another thing that we learned, so one of the top priorities would be really access to internet connectivity, or the ability to be able to meet privately with a resident in an area that maybe they have to quarantine. The second thing that was very much prominently learned is that infection control really ran the gamut. Yes, we had personal protective equipment. Yes, we were aware of testing. We were aware of vaccinations. The problem is that not everybody knew how to don and doff PPE. And while CMS did try to provide as much information to the states and local ombudsman, we actually had one local ombudsman, and that was in LA County, who helped create a don and doff PPE. And we used that statewide. This video was shared with volunteers and staff, and even staff in facilities. The tests, I think that's something, and we now have infection control and standards and protocols that are going to be normalized. So one of those areas is in tests. We found that it was very difficult to obtain tests, and in order to enter a facility, even initially when you were fully vaccinated, you needed weekly tests. So really a second big piece of learnings that we came away with is the federal government really needs to standardize and create a sustainable revenue so that facilities and volunteers in long-term care, ombudsman and surveyors will have access to not just PPE tests, and have easy access to those tests, because that was another thing that we found was very difficult. As you all heard from Nicole and others and Holly, it wasn't a surprise, but the lockdowns really prevented visitation from families, which resulted in declining health, emotionally, mentally, and physically. What we learned here is that communication was so disparate, depending on the federal government, the state, and the local. A third piece, and I'll be brief here, the two more pieces, but a third piece that we learned is coordination of communication and guidance, because there was guidance from CDC, for example, that was saying, as long as you're testing and you're wearing PPE, you can go in and visit with residents. And this was for ombudsman. However, we received many complaints from local ombudsmen that facilities just were not allowing them in, and were essentially saying that unless, until it was fully opened or the lockdown was lifted, that they were unable to come in. So we had to really emphasize through all of our all facilities letters, which are guidance, which is the guidance issued by the Department of Public Health, and the public information notices, which are the guidance issued by the Department of Social Services, to emphasize that ombudsmen are not visitors. We have not only a state and federal law that allows us to go in unmonitored and without any barriers, but more importantly, we need to be able to do this so that we can meet with residents. And as I mentioned, with even the ability to go in and do an investigation, or even to go in and witness an advanced care directive. The other, and these will be the last two items, the improper discharge. And I think you heard from Holly and her first example, improper discharge and what we refer to also as patient dumping. This was going on significantly. Yes, it's an ongoing problem, but what we needed to do and what I think we're learning from this is how do we incentivize in the funding so that there is more effort, so that if somebody is Medi-Cal only residents, that there isn't the discrimination by payment source, the lower income or individuals who are not private pay, and then also the 100-day clock on Medicare. That was another problem that we continue to see, where people were being transferred back and forth so they could start that Medicare 100-day clock. Last we'll say is that the biggest challenge that we're going to continue to see, and we do want to support, is the low wages of staff. CNAs and others, we are strong supporters, and we strongly would encourage that, not only under the direct care initiative, but we need to come together with facility, with the industry, with labor, with advocates to increase wages, improve training, and not just improve training with regard to infection control, but improve training with caring for people with dementia or with traumatic brain injury, because oftentimes the behaviors that we see are they result in medication and over medication of antipsychotic drugs. So we understand that low wages is a priority in California, and absolutely one of the areas that the Ombudsman Office is going to begin to really push and work to see the changes. The last thing I want to share is that going forward, some of the recommendations we believe need to be put in place immediately is that we've learned a lot from this pandemic. Infection control is here to stay, PPE, masks, all of those things are things that families are willing and ready to use. Isolation is not the answer. So finding ways that we can quarantine residents and make it easier for families to visit loved ones. And then also focusing resources, especially with nursing homes in underserved areas. We know that the pandemic was a real health disparities. People and communities of color were impacted significantly, and most importantly, we need to be able to create backup and staffing plans to replace staff when you have an outbreak of a virus in a facility. I'm going to close with sharing that the state ombudsman is supporting a number of bills, and I encourage you all to to reach out to your legislators and ask them to support. One of them was mentioned, AB 2546. It's the Resident Designated Support Persons Act. AB 277, it would increase the personal needs and maintenance. So instead of getting $35 a month when you're on Medi-Cal and in a nursing home, we would raise it up to $80 a month for personal needs. And then AB 1809, requiring resident informed consent when psychotropic medications are required, making sure that people know what medication is and what the impact is going to have. And then lastly is AB 895. This would require all skilled nursing facilities and residential care facilities to make sure that during admission, they clearly inform a resident about their ombudsman, how to reach their ombudsman, and give them the contact information. So with that, I'll turn it over to you, Sarah. Thank you.
Great. Well, thank you so much, Blanca. You provided a really important insights from the long-term care ombudsman's perspective about lessons learned during COVID and what you see, what the ombudsman feel are important priorities for system reform moving forward. And I think with all of this, I just, again, to ground us on what we're trying to focus on for the next 35 minutes, we want to understand how we can use this opportunity in California right now with the authorization of reauthorization of AB 1629. How can we utilize the payment reform for our skilled nursing facilities as a lever, policy lever for change to address some of these really critical issues we've been discussing today. So with that, I'm so pleased to introduce Eric Carlson. Eric is a senior staff attorney with Justice in Aging. And Eric, we know that Justice in Aging has been a key leader in advocating for the needs of older adults, including residents of long-term care facilities. What are Justice in Aging's key priorities at both the state and federal levels in regard to nursing home system reform?
Thanks, Sarah. I address them in this order: federal and then state, and then I want to talk personal for a second as well, because I think sometimes that gets overlooked. As Nicole mentioned, President Biden did introduce a reform package a few weeks ago, which is really promising, and it gives an opportunity and some momentum to actually make some progress on these issues. Along those same lines, just a couple of hours ago, the National Academies of Sciences, Engineering, and Medicine released their report, long in the works, on reform to the nursing facility system. It's 600 pages. I can't say I've read it yet, but by listening to the webinar, I have to say that there's a lot of promising things there that are very much in line with what the Biden initiative suggests, and which other folks may recommend as well. Nicole gave a little overview of the Biden initiative. I'll reiterate or add a couple of things. The Biden initiative includes some minimum staffing levels, which would be controversial federally, but incredibly important, because there's a lot of folks note every time this conversation comes up, it's all about the direct care and having enough people there, and the competence and availability of direct care, particularly CNAs, is critical. I just mentioned there are minimum staffing levels in California already. Although California is a bit of an outlier, a good outlier in that regard. More money for inspections, improved wages and training for direct care staff, better accountability for certification, so that the CMS and the state survey agencies would have more authority to really weigh the competence and good faith of the people asking for permission to be certified under Medicare and Medicaid, and also transparency, specifically better information on care compare, and also more extensive and understandable information related to a lot of corporate ownership and financial information. On the state side, as multiple folks have mentioned, the Medi-Cal rate is coming up for discussion this year. It is an extremely complicated topic. There's cost-based systems, there's acuity-based systems, there's outcome-based systems, and there's a whole industry on the facility side of people who work on maximizing reimbursement based on reporting and other factors. So it's going to be difficult given the budget timeline. As some assembly members pointed out in a hearing a couple of weeks ago, it would be nice to have a draft at this point. There isn't one. Because it's such a complicated topic, that's troubling, but once we see it, it's important for folks to push hard and to make sure that there is accountability and that the rate properly rewards good nursing facility care. I'll just mention here, as a veterans of the nursing facility reform wars, as it were, that there's so much conversation about money and accountability, and from the provider side, long-running complaints, as it were. I won't expect to claim to speak for providers. They can obviously speak for themselves and well, but a lot of complaints about the supposed inadequacy of rates and the Medicare subsidization of Medicaid and all the rest. It's just it's very contentious. It's very important, and it's because of that, it's critical that the state get it right, and that it's not just window dressing to say that this now is about equality. It has to actually be about equality. I'll quickly name check some of the legislation that's pending right now. Some other folks mentioned this. 1809, Assembly Bill 1809 requires informed consent for antipsychotics. Assembly Bill 2079 would require a minimum requirement that facilities spend a designated percentage of revenue towards direct care. Assembly Bill 1502 gives public health more control to ensure the competence of licensees. And then, as mentioned multiple times, Assembly Bill 2546 would create a designated support person who would have the ability to see a resident even during public health emergencies. And then quickly, the personal as well. And I say personal to point out that there's an incredible amount of important work to be done on the resident specific level. Ms. Lewis mentioned this, and she referenced that the ombudsman program and Cantor, and I know a lot of folks on this call are part of the aging network and have an incredibly important role to play. So sometimes in newspaper articles and other places, it suggests that nursing home reform is a matter about setting up levers, right? We set up some payment mechanism here. We put more information on the website here, and that's going to make nursing facilities better. But all that is true. I'm not downplaying that at all. But it's also incredibly important to have some impact on that personal level. I think facilities talk about this when they talk about culture change. When other people talk about culture changes, it's about changing the culture of facilities and changing the nature of those relationships. Residents have to, for better or for worse, it's important that residents and their family members and other people do that individual advocacy on a day-to-day basis to make sure that residents get what they're entitled to. Do a quick plug for our publication, 25 Common Nursing Home Problems and How to Resolve Them, in other resources and advocates as well. So important work to be done on the federal level, important work to be done on the state level, and also really important work to be done on that individual level by consumers, by facilities, and by other folks in the aging network.
Great. Thank you so much, Eric. That was a wonderful overview kind of where the advocacy opportunities are and what the perspective is on from Justice and Aging on the key reform needs at both the federal and state level and where these opportunities are. And now I'm really pleased that we can hear from the provider's perspective. Heather Craig is the executive director of Eschaton Care Facility in Greenhaven. And this facility was one of the facilities that did accept COVID patients, COVID individuals who were rehabilitating all throughout COVID. And no doubt, Heather, you have experienced the whole gamut of all of these issues that have been discussed today, including the workforce shortage issues, visitation issues, and just keeping your facility operating through very, very difficult times. So we really appreciate your being here. And what I would love to have you talk about at this moment is, what has it been like over these past several years to be the administrator running your nursing home? What challenges did you experience in COVID? And what do you take from those experiences as lessons learned that you can incorporate into the management of your nursing facility now and into the future?
Thank you, Sarah. It's my pleasure to be here. I am Heather Craig, the Executive Director at Escatong Care Center Greenhaven in Sacramento. We're a 148-bed not-for-profit nursing facility, and I've been the Executive Director at Greenhaven for over 17 years. I could speak for hours on all the topics that everybody has shared, and really appreciate the insights this is providing to people participating in this session. This morning, I'd like to share two key focus areas in skilled nursing that arose during the COVID pandemic. The first is physical plant and personal protective equipment for infection prevention and control. When we conducted our hazard vulnerability assessment in 2019, pandemic did not list in the top 10 of likely disasters, so we were not prepared. 2020 brought a new reality with COVID-19. 99% of skilled nursing facilities in California were built prior to 1980. Our facilities were not built for a pandemic. As I think Nicole said, most of our rooms are multi-occupant rooms. In my facility, they're semi-private rooms. Our rooms do not allow for 6 feet physical distancing. Even after rearranging the wardrobes and nightstands, once one of the residents gets out of bed, we can't maintain that essential 6 feet distance. So if one roommate got COVID, it was highly likely that their roommate would also get COVID. At the beginning of the pandemic, we had limited access to personal protective equipment. Nationwide, these supplies were on allocation to the acute care hospitals. With my experience as part of our County Emergency Preparedness Coalition, I was familiar with how to conduct a resource request to obtain PPE from our MOAC. Most nursing facilities were not familiar with the coalitions or the MOAC system. My facility was able to get sufficient PPE for our staff, including N95 respirator masks. However, we did not have access to fit testing kits. Without a fit testing kit, an N95 mask is not a safe respirator. Through our partnerships with a local ambulance company, we were able to get our frontline caregivers fit tested while we waited for our fit test kit that was also on national backorder. There are new regulations on PPE inventory for skilled nursing facilities, and this is very well intentioned. However, we need assistance with storage space for that PPE. The beginning of COVID, we closed down our beauty shop and turned it into PPE storage. Pre-COVID, skilled nursing facilities struggled for storage and office space, often converting closets into workspace. We need help with plans for our PPE storage. This has to go through a system formerly known as OSHPD and now known as HCAI. So our opportunities for reform for physical plant and infection prevention and control include being at the table in regulatory discussions with recognition of the physical plant constraints. Skilled nursing facilities need to have increased involvement in their county emergency preparedness coalitions. Cost and regulatory challenges need to be considered as we modernize our aging and outdated nursing facilities. The second area I'd like to focus on is workforce shortage and care force development. Prior to COVID, we were already facing a workforce shortage. The aging tsunami was gaining momentum and baby boomers were retiring. COVID expedited this exodus, which has come to be known as the Great Resignation. Long-term care providers lost care workers to acute care, corrections, and predatory registry market that affords to pay workers at higher wages. Long-term care is not seeing the resurgence in workforce that is happening in other healthcare sectors. Pre-COVID, OSHPD predicted that California would need 20,000 more CNAs by 2030. This seemed a daunting number 2 years ago. Now, HCAI, formerly OSHPD, is reporting that California needs 20,000 more CNAs by 2025. For the first 15 years of my work at Escatong Care Center Greenhaven, we had not used registry CNAs. Right now, we have 24 full-time CNA openings, 9 full-time RN openings, and 6 full-time LVN openings. These positions have been open since before October 2021, and so we have to use registry. We have had to deny new admissions when we do not have enough staff to care for them. Escatón has implemented a variety of workforce initiatives. For the first year of the pandemic, employees received an hours worked bonus each pay period. Employees who volunteered to work our COVID unit received a 20% pay increase. In early 2021, we increased wages for our LVNs and CNAs. In mid-2021, we implemented a fully paid CNA training program, but we have yet to fill a full class. In late 2021, we increased on-call rates for RNs, LVNs, and CNAs to be competitive with the registries. We still don't have enough staff. At the start of 2022, we increased the starting wage for CNAs to $20 an hour to recognize and retain our dedicated caregivers. So our opportunities here are needing an investment in our long-term care force. We need living wages for all staff. We need training grants for career growth and development. We need new research on staffing levels and a plan on how we get there to get to those levels. We need regulatory investigation and oversight on registries and on price gouging. I thank you for the opportunity for participating in this discussion. I see a lot of great comments in the chat box, and I look forward to your questions.
Thank you so much, Heather. Such an important perspective to hear, and thank you for the hard work of you and your team over these past several years. You know, it's so critical, and we appreciate hearing from you. So now I think it's a great segue. We're going to hear from Nicole again right now, because Nicole has been focused a lot on addressing this workforce issue. That's so much of the challenge that we hear about today across the continuum of care in skilled nursing facilities, assisted living, in home and community-based services, and in the medical care setting. So Nicole, we would love to hear how you have approached this, and specifically looking at the Healthcare Career Pathways Program and what you see as opportunities to build the pipeline of workers and to develop more of a career ladder approach to professional development. So thank you, Nicole.
Thank you, Sarah. This is a multi-pronged issue. This, it's interesting to think of the way that we can improve resident care is actually by improving conditions for the workforce. So a few years ago, Empowered Aging, along with Mount Diablo Adult Education and Opportunity Junction, a job training organization, all kind of came together through magic, saying either, I was saying my team members and I are tired of looking at complaints related to lack of staffing, lack of trained staffing, or lack of consistent staffing. Opportunity Junction was saying we're hearing from a lot of job seekers that they want to enter the allied healthcare field. And Mount Diablo was an adult school that had expertise in previously hosting a certified nursing assistant program. So he said, we want to do this, but we don't want it to look like anything we've ever seen. And in California, to become a CNA, that takes 160 hours. It's 1 month of full-time training. Well, we said we're going to be 303 hours. And we thought, gosh, the folks who are in skilled nursing facilities, Medi-Cal beneficiaries, are by definition, low-income individuals, folks who've maybe had some struggles. So we thought, let's maybe find students who also have had similar struggles. Let's find students with addressable barriers, maybe who couldn't find their way to a community college alone, someone who maybe has been homeless, who struggled with addiction, first in their family go to post-secondary education, all those things, self-doubt, those things we all have. Let's design a program for them. Let's steep it in person-centered principles. And I'm just going to tell you guys something. Student-centered principles are the same as people or person-centered principles. If we treat our students with respect and dignity, they hold that and they take that into the workplace. We're going to bake it with restorative justice principles. And we're going to throw in a lot of supports like common sense, like everyone should eat lunch together, like family style, let's reinforce those good norms, going to home with food on the weekends. And what we've seen 3 years later is 80% of our students are still working in the long-term care system. Those students who literally got cut off in the middle of COVID came back to finish class and to do their certification test. And so we've been really successful with it. It now lives in both Concord and Contra Costa County and Antioch and Contra Costa County at 2 different sites. And we're looking to expand to additional sites over the next few years. We have funding through the California legislature to do that. And we're looking first at Alameda County because it is a great representation of California in many ways, diverse, large opportunities, transportation. I think what is critical to understand that we have to realize it takes support to get into the allied healthcare field. Our CNA should not be paying $2,000 for training to go do a job where they're still terribly underpaid at $17 or $18 for it. That should be provided to them. Additionally, we can't simply say, well, okay, go to that class, you're going to be fine. Because you might need things like a watch with a second hand, scrubs, you might need appropriate undergarments to go underneath that. You might not have a way there, but if you give your cousin a gas card, they'll drive you every day to class. You maybe don't know those soft skills, the kind of managing up, how to navigate. Our program has that. Now, we're still a CNA program, and I think that's great, but we're now at the place that we're starting to look at what lattices and what ladders can be put in place to help our students and others move up. Can they become LVNs? If they become LVNs, is there a path to RNs? Could they go into other things like social work? Could they be the social work designee at a facility? You know, there is no better social work designee or activities coordinator than a former CNA. And it also means looking at the way that what we're requiring of CNA programs. We have this little thing in California that in order to launch a CNA program, it requires that you have a director that is an RN, that has worked in long-term care for a period of time, that has also taught students. Those are three really hard things to come by when we already have a shortage of RNs. I would like our California to mirror other allied healthcare fields like EMT, medical assistant, phlebotomist, dental assistant. In those instances, students are able to have their skills signed off on by experienced medical assistant, EMTs, etc. Who better to sign off on the skills of a CNA than someone who's been doing it 3, 5, 10 years and obviously has a heart for this, right? We need our RNs out on the front lines of healthcare, either with patients or developing policy or leading healthcare entities. Let us move away from that regulatory structure that is unnecessarily cumbersome. And I think you're going to see if you address those issues, you're going to have really an opening. Healthcare is consistently on the top of the list of professions that folks want to enter, but we need to make it easier to get in, and we need to recognize that not everyone comes to the first day of class with an easy life, but they can be successful with appropriate supports. Thank you.
Thank you, Nicole. It's so wonderful, the approach that you've taken. And we would love to hear when, after we get through some of these questions, we have about 10 minutes, but would love to hear more about your thoughts on how to scale up this sort of a program and what some of the proposals are. We have 2 hands raised for questions, and I'm going to call first on let's see here, Chelsea Driscoll, who's had her hands raised since the beginning, and then Jeannie Parker Martin as well, who might be able to speak to some of the Leading Age California's initiatives aimed at the building off of the Healthcare Career Pathways program. So first I want to, and then we'll go to Susan LaPadula. So Chelsea, we will unmute you at this moment. Welcome.
Hi, I think I accidentally hit that button a while back. I did not have anything I wanted to say. So
okay,
sorry.
Great. No problem. Thank you for being here. Okay, so Jeannie Parker Martin, we would love to hear from you. And everybody introduce yourself before you speak, please.
Hi, thank you, Sarah. And I just want to thank all of the panelists. The comments from a caregiver perspective by Holly, Blanca's perspective as an ombudsman, and some solutions that you presented, Eric's comments on both the federal, state, and then personal perspectives were excellent. Heather, from the on-the-ground standpoint, really telling about the struggles that providers were dealing with, and then pairing them with the individual caregivers and the residents that you were dealing with. And Nicole, finally from you, your work not only in understanding the bigger picture of the overview, but also in caregiving development. And I'll build on that in just a second. So I want to just follow on something that Eric said, because it's really important. The National Academies of Sciences, Engineering, and Medicine report that was released, and the link was put in the in the chat a little bit earlier. And then Eric and I had the honor of serving on the Coronavirus Commission for Quality and Safety in Nursing Homes in 2020. It seems so long ago now. But those recommendations closely align with each other. And I think there are a couple of key points that overlap. And now we have a need to execute on the recommendations. We can't continue to look and study, but really have to execute, which will ultimately get to Nicole's comments. The realignment of financing in Medicare, which we're in the Medi-Cal program, which we're looking at in AB 1629, also in the Medicare program that will have to occur. We must increase the wages for CNAs and also look at those training and ongoing development costs and items. The need for equitable care that's outlined in the National Academy's report, and also the ongoing need for transparency and understanding the right approaches to making sure that there is transparency and also that everyone is held accountable for the work that's being done, whether it's in nursing homes or in other health facilities. So I think as we continue to evolve the AB 1629 discussion this year, which really only addresses financing issues, we have to wrap around all these other considerations and make sure that the elements of each of the speakers today are integrated into our conversations and to the outcomes that occur in the various bills that Eric outlined, but also in AB 1629. I want to also mention that Nicole's efforts at Empowered Aging have allowed Leading Age California to accelerate training and development opportunities. And we are going to be implementing and executing on a fairly widespread training and development program, hopefully launching on July 1st of 2022, that will increase CNAs by 2,700 CNAs and home health aides over a 3-year period, along with many of the wraparound services that Empowered Aging highlighted in their initial work, and also some additional incentives and pathways to help continue developing as well as training individuals who are currently CNAs. So we're looking forward to collaborating with many organizations on this opportunity and look forward to building the workforce beyond where it is today. So thank you again to CDA for highlighting what the elements of the MPA are, of which this is a very important one. So thank you, Sarah.
Absolutely. Thank you so much, Jeannie, for building out those comments as well. So I want to first turn to Susan LaPadula, then Michael Wasserman. If we have time, Tracy Weirick, we will turn to you, but I just note that we have about 5 minutes left till we will be closing. So thank you everyone for your chat and remarks and comments. We will be having this recording available. So appreciate your all weighing in. So Susan LaPadula, welcome, and thank you for introducing yourself as well.
Good morning. Hello, everyone. Thank you to an incredible array of speakers and professionals. You've made this time extremely beneficial to us all. My name is Susan LaPadula. I work and live in Contra Costa County, and am very pleased with all of Nicole's work and her team. It's incredible to have that team in our county. I'd like to talk from a family member's perspective and give a nod to Holly for all of the information she shared. And one thing I think we forgot about is upon admission, when our family member is admitted to a nursing facility, it's overwhelming, emotionally heart-wrenching, and the paperwork that you're handed on that day is incredible. So learning about our ombudsman and meeting and being introduced may get buried in the paperwork and in that day. Perhaps in the future, we could look at reintroducing the ombudsman somewhere throughout the stay so that family members can process and adjust to this new transition, and then know that they have an option to be heard and someone who will stand next to them shoulder to shoulder. So that's something I would love to share with you all, remembering how overwhelming that whole process can be on families and the paperwork. also I'd like to bring to your front of your mind is that in a facility, legally, there needs to be a consumer board, some kind of cork board or a beautiful plexiglass board that introduces consumers to some of their options. I'm not sure that's ever given to the family members as a place to seek what they need to know. And perhaps we can increase that visibility upon introducing them to a skilled nursing facility and letting the family members know that these are their options. These are safety nets that have been put in place that they may never had to think about before because they've never had to bring a family member to a nursing home. Last but not least for Holly, and perhaps for the future, is that there are residential family councils within the nursing home that some families may choose to be a member of. Certainly, when my family was in the nursing home, our family was a member of that council because that's really where you hear about the day-to-day, and you hear it from family members and other residents. So perhaps that's something we can share. And last but not least, remembering that there's a possibility to refuse medication. So if your family member should not be taking that medication, there is an option to refuse. Just because it's coming through doesn't mean you have to take it, especially the psychotropic medications. Thank you so much to everyone.
Thank you so much, Susan, for that really important perspective. Again, reiterating the caregivers' important perspective. We have just a few minutes left, but we want to hear from Michael Wasserman of the California Long-Term Care Medicine Association. Michael, welcome. And then we will have to close it up after that point.
And I'll be quick. And I think Susan's comments before me were outstanding. The panel was outstanding. I'm just going to make one plug based on AB 749. We will be raising the bar, the competencies of medical directors throughout the state of California in the coming years. There are facilities that have certified medical directors already. I think engaging medical directors is going to be a key tool to addressing a lot of these issues. We acknowledge there's a lot of medical directors who don't have the training and who aren't engaged. We want to work with everyone to change that. So anyway, CalTCM, we represent an interdisciplinary group of folks who really are focused on improving quality of care to our most vulnerable. And so we're here to work with everyone. We put in the chat box a few of our recent white papers. Last comment on that, we're actually presenting at the CMS Quality Conference a pilot proposal for community resident and family councils to actually engage communities, particularly communities of color, where we have nursing facilities with high percentages of people of color, getting the communities actively involved in those facilities. So look forward to working with everyone going forward.
Thank you so much, Michael. I appreciate that very much. And I'd like to turn it now to Susan DeMorris, Director of the Department of Aging, for a few closing remarks. Thank you for all for being here. And thank you so much to our amazing panelists. Really appreciate your perspectives.
I share Sarah's thanks to our panelists, and you know, a 90-minute webinar will not unravel these complex issues that are a combination of federal and state policy, many of them longstanding. But I have so much confidence in the panelists today who are, you know, we all heard from leaders, nationwide and statewide leaders, and there are many, many more throughout our state. So I have confidence that the experts and the advocates in our state can work together to improve the quality of life for residents in nursing homes and for the employees in nursing homes as well. So I just want to thank everybody for giving their time today. And to remind you at the start, I said this is just a continuation of an ongoing conversation. And I can tell you that during the pandemic, we formed a congregate care work group, and that group continues to meet, and they will be meeting this Monday. So many of the individuals you heard from today, either in the chat or as panelists, are part of that work group, and we will be continuing this conversation. So please keep the communication coming to the governor's office, to the legislature, to the Department of Aging, through all the organizations that you're part of. Please just keep the communication going and the conversation active. And thank you all for joining us today. And we'll see you at our next webinar in the month of May. Thank you so much.